Good afternoon, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have a few housekeeping items. This CME activity is jointly provided by the Queen's Medical Center and the University of Hawaii John A. Burns School of Medicine, Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CMEs. You can find the evaluation by following the link in the chat at the end of this presentation, or on our email advertisement, or on our website. CMEs will be sent out by our sponsor in mid-January. Your comments are very important to the planning committee and will be used to plan future programs. At every Grand Rounds, we also talk about conflicts of interest. Our speaker today has no conflicts of interest related to this presentation. It's my great pleasure to introduce Dr. Angela Lowe. She's a clinical assistant professor of medicine at Stony Brook University in New York, where she had attended as a medical student and also completed her internal medicine residency. She currently serves as an attending preceptor at the Internal Medicine Resident Primary Care Continuity Clinic. Many of you will recognize her because Angela recently graduated from our own Geriatric Medicine Fellowship Program. So we're particularly thrilled to see her and to welcome her as our presenter today. Welcome, Angela.
Thanks so much, Dr. Misaki. Thank you for having me today. So today I will be talking about osteoporosis. I'll be reviewing the current treatment guidelines and latest therapeutic options. And just as an overview, I'll also go over the current guidelines on osteoporosis screening, diagnosis, and treatment, comparing the different therapeutic options for osteoporosis, and also discussing the latest therapeutic options. So the incidence of osteoporosis in women is greater than heart attacks, strokes, and breast cancer combined. And per the Bone Health and Osteoporosis Foundation, formerly known as the National Osteoporosis Foundation, osteoporosis unfortunately caused more than 2 million fractures in 2005. And in 2025, there's going to be an estimated more than 3 million fractures from osteoporosis. 1 in 2 women and up to 1 in 4 men over age 50 will have a fracture due to osteoporosis. And every year, of nearly 300,000 hip fracture patients, about a quarter of them end up in nursing homes and about half never regain previous function. So it's something that we really need to address in our patient population. For a diagnosis of osteoporosis, we need a bone mineral density measurement of less than or equal to 2.5 standard deviations below the young normal adult reference. Also, it would be a t-score less than or equal to negative 2.5. Or there should be a minimal trauma fracture of the spine, proximal humerus, hip, and or forearm in a patient with osteopenia. That is a t-score between -1 and -2.5. And just of note, a low trauma fracture is defined as any non-pathologic fracture that occurs from a fall from standing height or less. Just to go over the WHO definitions. So normal bone mineral density is when the t-score is greater than or equal to -1.0. Osteopenia is when the t-score is between -1 and -2.5. Osteoporosis is when the t-score is less than or equal to -2.5. And severe osteoporosis is when the t-score is less than -2.5 and there is a fragility fracture present. So with regards to screening, I'm going to talk about the USPSTF screening as well as the Bone Health and Osteoporosis Foundation screening guidelines. For USPSTF, they recommend screening for osteoporosis in women 65 and older and those younger than 65 who are at increased risk. And that's as per a formal clinical risk assessment tool. Unfortunately, at this time, there's insufficient evidence to balance harms and benefits of screening in men. The clinical risk assessment tools that USPSTF recommend using include the SCORE risk, which is from Merck, the ORAI, or the OSIRIS, or the Osteoporosis Self-Assessment Tool, or the FRAX tool, which we probably most commonly know. And just of note, when we use a FRAX tool, we want to look at whether or not the risk for osteoporosis is greater than that of a 65-year-old white woman of mean height and weight without major risk factors. And so that 10-year risk is about 8.4% for major osteoporotic fracture. For the Bone Health and Osteoporosis Foundation, they recommend screening for osteoporosis for women 65 and older, men who are 70 and older, anyone who has had a broken bone after the age of 50, women aged 50 to 64 with risk factors, or men aged 50 to 69 with risk factors. And the risk factors they consider include a family history of osteoporosis and/or fracture, frequent falls, vitamin D deficiency, smoking, excessive alcohol intake, malabsorption, and the use of certain medications such as prednisone. Along that, you might consider vertebral fracture assessments. So unfortunately, vertebral fractures are highly associated with future fracture risk and morbidity, and it could be present in those with T-scores better than or greater than -2.5. And this can also be used as an adjunct to BMD testing. This can be done at the same time as your DEXA scan. So the indications for the vertebral fracture assessment, as per the International Society for Clinical Densitometry, include for those with T-score less than -1, and they are either women that are greater than 70 years of age or men greater than 80 years of age. If there's been a greater than 4-centimeter historical height loss, a previous vertebral fracture, including self-reported vertebral fractures, or a history of long-term systemic corticosteroid use, so more than 3 months use. Risk factors for osteoporosis include increasing age, female sex, BMI less than 20, a 10% decrease in weight from their baseline, physical inactivity, use of glucocorticosteroids, a previous fragility fracture as male, white or Asian race, current smoking, low dietary calcium, and 3 or more alcoholic drinks per day. So unfortunately, there are many medications that increase risk for osteoporosis. One of the most common medications is glucocorticoids. There's about 2.5% of people 70 to 79 years old who take an oral glucocorticoid. And glucocorticoids cause osteoporosis through increased bone resorption. And this increased fracture risk can be present with daily dosages as low as 2.5 to 7.5 milligrams per day. Other medications include anticonvulsants. Phenytoin and carbamazepine are examples, and they have a direct effect on bone cells, calcium, and bone metabolism. Long-term heparin use can also cause bone loss through osteoclastic resorption. Excess thyroid replacement also directly stimulates bone resorption. Methotrexate is known to inhibit osteoblastic differentiation. Calcineurin inhibitors also reduce osteoblast differentiation. Protein pump inhibitors decrease intestinal absorption of calcium and thus result in bone loss. And then GnRH agonists, such as those used for prostate cancer, or aromatase inhibitors, such as those used in breast cancer, ultimately decrease estrogen, which can result in bone loss as well and increased bone resorption. And then in chemotherapeutic agents, these can lead to senescence in cells. So these are when cells stop multiplying but don't die when they should, leading to bone loss. And also some chemotherapeutics such as doxorubicin and cisplatin can cause reduction of calcium as well. And then SSRIs and antiretrovirals are also associated with osteoporosis risk. There are also common secondary causes of osteoporosis. These include male hypogonadism, vitamin D insufficiency, idiopathic hypercalciuria, malabsorption disorders such as celiac disease, multiple myeloma, glucocorticoids use, primary hyperparathyroidism, and solid organ transplantation. And for these patients with transplants, it's typically due to the steroids and the calcineurin inhibitors that they have to take. So some initial lab tests that we should be doing for our patients when we find them to have osteoporosis include a complete chemistry profile, getting a complete blood count, calcium levels, phosphorus levels, and vitamin D levels. For men, we additionally recommend ordering testosterone levels and a urinary calcium excretion examination. And then if clinically indicated, there are further tests we should go for, such as an intact parathyroid hormone level, a thyroid stimulating hormone level, tissue transglutaminase to evaluate for celiac disease, SPEP and free light chains to evaluate for multiple myeloma, urinary free cortisol levels to examine for adrenal hypersecretion. In some cases, mastocytosis can also cause osteoporosis. So you check for serum tryptase or urine N-methylhistidine. Just of note, mastocytosis is a disorder of abnormal mast cell proliferation, and clinical features include flushing, pruritus, abdominal pain, diarrhea, hypotension, syncope, and musculoskeletal pain. And if there's also concern for marrow-based diseases, you could also consider bone marrow aspiration and biopsy. So who do we treat? So for postmenopausal women and men greater than or they're at 50 years old, we do recommend treating those with osteoporosis whom we criteria by DEXA, or if they have a history of hip, vertebral, or prior fragility fracture, or if they have a T-score between -1 and -2.5 at the femoral neck or spine, and there's a 10-year probability of fracture that's greater than or equal to 3%, or if there's any major osteoporosis-related fracture risk of greater than or equal to 20%. And this is as per the Endocrinology Society clinical practice guidelines. So additional considerations in treating patients with osteoporosis. So you would want to consider any patient with more than 1 year of remaining life expectancy. There unfortunately isn't any clear guidelines for when to start pharmacologic treatment after a fragility fracture, but the general consensus is to start 14 days after an acute fracture. Also, we should take into account patient preferences, fracture risk profile, harm, benefits, and cost of medications. So I'll be going over the pharmacologics, including bisphosphonates, the SERMs, calcitonin, estrogen replacement, parathyroid hormone, RANKL inhibitors, and investigational agents. And then just of note, there are additional recommendations for those with osteoporosis and prevention of osteoporosis. So that includes exercise, which is really important. It was included, or it was found in a Cochrane review that exercise does increase bone mineral density. And so these exercises include strength training, aerobics, Tai Chi, and walking, and of course, calcium and vitamin D supplementation. So with regards to calcium intake, so this is per the American Association of Clinical Endocrinologists. So for males and females who are between 19 and 50 years, they do recommend 1,000 milligrams per day of calcium. And then for males who are between 51 and 70 years, they recommend 1,000 milligrams per day of calcium. And then for females between 51 and 70 years of age, they recommend 1,200 milligrams per day of calcium. And then for those who are 71 years and older, for both males and females, they recommend 1,200 milligrams of calcium per day. And the upper intake recommended is 2,000 milligrams per day. And foods that are high in calcium include canned sardines, dairy products, canned salmon, legumes such as beans or lentils, green leafy vegetables such as bok choy or kale, tofu, edamame, nuts such as almonds, and seeds such as chia seeds or sesame. So these are all high sources of calcium. And then we also see calcium supplementation. So unfortunately, the average calcium intake for Americans is about 600 milligrams per day. So not quite where we want it to be. And so if our patients can't get that adequate calcium supply, we can recommend supplementation as well. Just of note, though, for optimal absorption, calcium supplementation shouldn't exceed 500 to 600 milligrams per dose, whatever the preparation is. And so if there are patients who require more than 600 milligrams of calcium supplement daily, that dose should be divided. And there are two different types of supplementation out there. We see calcium carbonate, and then we also see calcium citrate. So just of note for calcium carbonate, this can cause constipation and bloating. And because it is dependent on gastric acid for absorption, it's best taken with meals. On the other hand, there's also calcium citrate, which is often more expensive, and it does require more tablets to achieve desired dose. However, this is less likely to cause GI upset, and it's not dependent on gastric acid, so it doesn't necessarily need to be taken with meals. And then for vitamin D intake, the recommended daily amount is 1,000 international units per day for adults aged 50 years and older, also per the American Association of Clinical Endocrinologists. And then per the National Academy of Medicine, the upper limit that's safe is 4,000 international units of vitamin D per day. The optimal level is controversial. So the AACE and the Endocrine Society recommend a higher level. So that's 30 nanograms per milliliters or more. And the reason why is because secondary hyperparathyroidism is increasingly common as these 25-hydroxy vitamin D levels fall below 30 nanograms per milliliter. However, other groups do recommend 20 nanograms or more as adequate. So that's the NIH and the National Academy of Medicine. And just of note for patients with CKD and CKD 3 and 4, we do recommend calcifediol vitamin D levels of 50 nanograms to help with secondary hyperparathyroidism. And good sources of vitamin D include sun exposure, cod liver oil, salmon, tuna, swordfish, so fatty fish like these, fortified cereals or juices like orange juice, or also non-dairy milk as well, and dairy milk, or canned sardines or egg yolks. And then there's also vitamin D supplements over the counter that we prescribe. And so there are different formulas such as cholecalciferol, which is D3, or ergocalciferol, which is D2. So of note, D3 or cholecalciferol is recommended over ergocalciferol. And the reason is that many current assays and labs are inaccurate in measuring ergocalciferol, or D2, if there is a significant amount of ergocalciferol. So basically, it's hard for us to assess vitamin D2 as well as D3. Okay, so now moving on to bisphosphonates, our therapies. So this is one of the mainstays of our therapies for osteoporosis. And the main medications from this class include alendronate, risedronate, ibandronate, and zoledronic acid. Many of you are familiar with these medications. So with alendronate, this is one of our oral bisphosphonates. It could either be taken as treatment or prevention for osteoporosis, 70 milligrams per week for treatment, 35 milligrams per week for prevention. And it is observed to have benefits for reduced fracture reduction with vertebra, hip, and non-vertebra fracture reduction. There's also risedronate, which also could be used for prevention and treatments. So this is either a daily, weekly, or monthly dosing. And it also shows vertebral fracture, non-vertebral fracture, and hip fracture risk reductions. There's also ibandronate, which is either 150 milligrams oral per month for both treatment and prevention, or just like Q3 monthly IV treatment as well. And that's just for treatment. This, however, ibandronate is only shown to have risk reduction for vertebral fractures. And then finally, there's also zoledronic acid. And this is once yearly treatment for osteoporosis. And then for prevention, you could do this Q2 years. And this also shows observed benefits for vertebral fracture, non-vertebral fracture, and hip fracture risk reduction. A little bit more about bisphosphonates. So these are not recommended when the creatinine clearance is less than 30 And for oral bisphosphonates, we should be having our patients take them on empty stomach with at least 8 ounces of plain tap water. They should remain upright for at least 30 minutes after ingestion to avoid esophagitis. And with alendronate and bisphosphonates, they shouldn't ingest anything for 30 minutes for appropriate absorption. But with abandronate, it should be longer. They shouldn't ingest anything for 60 minutes after taking that medication. And then with regards to bisphosphonates, they are associated with atypical fractures, such as subtrochanteric and diaphyseal femur fractures. So we want to monitor patients for any new groin pain or thigh pain, and we want to let us know if there's new pains in those regions. And then there's also a low risk for osteonecrosis of the jaw. And the incidence, though, is 1 in about 10,000 patient years. So the optimal duration for bisphosphonates is unclear. There was a FLEX study that was done in 2006, noting that it could be discontinued after 5 years of treatments in patients with low risk of future fracture. For the AACE, they recommend considering a drug holiday after 5 years of treatment if fracture risk is no longer high. That is, if the T-score is greater than or better than -2.5, or the patient remained fracture-free while on treatment. But you can continue treatment for up to another 5 years if that fracture risk remains high. Per expert opinion, they recommend a discontinuation of bisphosphonates when a person is no longer ambulatory or has a remaining life expectancy of less than 2 years. I'm going to move on to another class. So this is a selective estrogen receptor modulator, mainly raloxifene. So raloxifene is an estrogen agonist in the bone and heart, while it's an estrogen antagonist in the breast and uterine tissue. It is shown to reduce vertebral fractures, but it hasn't been shown to reduce hip or non-vertebral fractures. So this may be helpful in those with discordant BMD, basically a low BMD of the spine, but not hip. This could be an acceptable initial choice for those who need osteoporosis treatment and are at high risk of breast cancer. Raloxifene is oral. It's 60 milligrams daily and can be used for both prevention and treatment of osteoporosis. However, there is an increased risk of venous thromboembolism and fatal stroke. Side effects include flu-like symptoms, hot flashes, leg cramps, and peripheral edema. And when we do stop raloxifene, the skeletal benefits appear to be lost pretty quickly during the next 1 to 2 years. So if this medication has to be stopped, we should consider additional therapy after that. Calcitonin inhibits bone resorption. This medication is known to decrease vertebral fracture risk, but it doesn't decrease hip or non-vertebral fracture risk. And of note, there is a minimal increase of BMD at the spine with this medication. It's also known for a possible analgesic effect in women with painful vertebral compression fractures. Similar to raloxifene, the skeletal benefits are lost relatively quickly during the next 1 to 2 years after discontinuation of the medication. And because more effective agents are available, we recommend limited use of calcitonin as long-term treatment for osteoporosis. It is used intranasally or as sub-Q or IM. It's 200 international units intranasally once daily or 100 international units sub-Q or IM daily. And adverse effects include hypocalcemia, nausea, vomiting, and an allergic reaction. There is also a possible increased risk of cancer with this medication. There was a meta-analysis of 21 randomized controlled trials done by Wells et al. In 2016 of nasal calcitonin and oral calcitonin, which showed a higher incidence of malignancy in the calcitonin-treated patients. However, the FDA did not find sufficient evidence to establish causal relationship between calcitonin and cancer risk, and that's why it still could be used. So estrogen replacement was also previously considered the treatment of choice for postmenopausal osteoporosis. However, it was never specifically approved for this use. Estrogen can prevent bone loss at the hip and spine when initiated within 10 years of menopause. However, Women's Health Initiative did show a decreased hip fracture risk, vertebral fracture, and colon cancer, but there was increased risk of breast cancer, heart disease, stroke, and venous thromboembolism. So the USPSTF advises against the use of combined estrogen and progestin for the primary prevention of chronic conditions in postmenopausal persons. It was approved by the FDA for prevention of postmenopausal osteoporosis. However, they do note when prescribing solely for the prevention of postmenopausal osteoporosis, therapy should only be considered for women at significant risk of osteoporosis and for whom non-estrogen medications are not considered to be appropriate. And just a note, there is a combination medication for osteoporosis with conjugated estrogen and a SERM. So this is also known as Duavy. So Duavy is combines conjugated equine estrogen with a selective estrogen receptor modulator. FDA did approve this with the rationale that this combination could improve bone mineral density while reducing hot flashes without some of the adverse effects on the endometrium and breast-associated breast effects associated with estrogen therapy alone. There was a study done by Lindsay et al. In 2009 noting that this Duavy medication does increase bone mineral density at multiple sites while reducing severity of hot flashes and improved vulvar-vaginal atrophy. However, this medication does have multiple black box warnings, including increased endometrial cancer risk, and a recommendation not to take additional estrogens in addition to this medication. This medication is indicated for women with a uterus and with moderate to severe vasomotor symptoms associated with menopause and the prevention of postmenopausal osteoporosis. And the dosing, it is a once daily oral medication, 0.45 milligrams of conjugated estrogen and 20 milligrams of bisodoxifene. And adverse reactions include diarrhea, nausea, dyspepsia, upper abdominal pain, muscle spasms, dizziness, neck pain, and oropharyngeal pain. So now moving on to anabolic agents, or also known as the parathyroid hormone analogs. So this includes teriparatide and abaloparatide. So teriparatide was actually approved for treatment of men with primary hypogonadal or glucocorticoid-induced osteoporosis. Both teriparatide and abaloparatide are approved for initial treatment for postmenopausal women with osteoporosis who are at high risk of fracture or have failed or have been intolerant of previous osteoporosis therapy. Both teriparatide and abaloparatide do require subcutaneous injections daily. That's a little tough with patient compliance. And prior to starting these medications, it's recommended to check serum calcium, parathyroid, and vitamin D levels, and alkaline phosphatase to rule out Paget disease. It does increase BMD and reduces vertebral and non-vertebral fracture risk in women with postmenopausal osteoporosis. Side effects are present, but they're noted to be mild and transient, and these include nausea, orthostatic hypotension, and leg cramps. So just of note, these anabolic agents should not be used in patients at increased risk of osteosarcoma. So those include those with Paget disease of the bone, a history of irradiation involving the skeleton, or an unexplained elevation of alkaline phosphatase level of skeletal origin. So in line with that, it should be avoided in those with primary or any form of secondary untreated or unresolved hyperparathyroidism. These medications are also expensive. And we should be limiting these medications to no longer than 2 years in total duration and should be followed by an anti-restorative therapy such as bisphosphonate or denosumab followed by an oral bisphosphonate. So now moving on to denosumab. So this is a monoclonal antibody preventing the receptor activator of nuclear factor kappa B ligand from binding to its receptor. So this essentially reduces precursor cells differentiating into mature osteoclasts. There's been studies of treatment with denosumab for up to 10 years with good safety profile. It is a Q6 monthly sub-Q injection of 60 milligrams, and it has shown to reduce vertebral, non-vertebral, and hip fracture risk. It's not contraindicated in patients with renal insufficiency, and no dosage adjustment is required. However, for those with significantly impaired renal function, there is a risk of hypocalcemia. So it could also cause significant hypocalcemia in those with hypoparathyroidism, thyroid or parathyroid surgery, history, malabsorption syndrome, excision of small intestine. And similar to bisphosphonates, there is a rare side effect of osteonecrosis of the jaw. So one of the latest therapeutics out there includes romosozumab, also known as Evenity. So this is a monoclonal antibody that's directed against sclerostin. This is a cytokine that inhibits bone formation and stimulates bone resorption. So the approval for this medication for postmenopausal women at high risk for fracture was based on 2 trials. The first trial was done by Kosman et al. Back in 2016. This study included about 7,000 postmenopausal women with a T-score that was between -2.5 and -3.5. They were randomly assigned to romosozumab or placebo for 12 months, and then each group received denosumab for 12 months after that. The second trial was done by Asag et al. Back in 2017. This was a slightly smaller study with about 4,000 postmenopausal women with osteoporosis and a fragility fracture. So these women were assigned to romosozumab or weekly alendronate for 12 months. This was double-blind, double-dummy, and then both groups received alendronate. So both trials actually showed significant reductions in radiographic vertebral fractures with romosozumab. There was found to be a 73% reduction versus placebo at 12 months, and a 48% reduction versus alendronate at 24 months. Clinical fractures were also significantly reduced in both trials. Non-vertebral fracture reduction were significant only in the smaller trial at 24 months. That's the one with Sag et al. There was another study done in 2017 by Longdahl with 436 patients who had at least 3 years of oral bisphosphonate therapy, who were then assigned to 12 months of either romosozumab or teriparatide. Here, greater gains in bone mineral density were seen in romosozumab in the lumbar spine, femoral neck, and total hip. So romosozumab will likely be viewed as a rescue drug for those at very high fracture risk. It is an option for those previously treated with teriparatide or abaloparatide. And these can be used in patients with prior radiation exposure, unlike the PTH analogs. In the smaller of the phase 3 trials, Sag et al. In 2017, unfortunately, serious cardiovascular events were significantly more common with romosozumab compared to alendronate control group. And there is a black box warning because of this for romosozumab that it should not be used in patients at high risk for cardiovascular events or those who have had a recent MI or stroke. There is a trial right now going on for males with romosozumab, but unfortunately it's not currently approved for male osteoporosis. A little bit more about romosozumab. It is a subcutaneous injection once monthly, just up to 12 months. We limit this treatment to 1 year, and then we follow up with a drug for long-term use, such as a bisphosphonate or denosumab. Adverse reactions include arthralgias, headaches, muscle spasms, peripheral edema, and insomnia. So overall, for monitoring for osteoporosis, we do want to do serial bone mineral densities while on therapy. This is pretty common. Actually, a 2-year interval is currently covered by Medicare. But there is limited evidence for modifying treatment based on bone mineral density. But we do want to check out the bone mineral density every so often to watch out for maybe adherence, maybe to consider secondary causes Or if there is continued decrease in bone mineral density, we might be considering a failure of treatments and thus adjusting to a different therapy. And then if there were 2 or more fragility fractures while on treatment, this can also be evidence for treatment failure. And I just wanted to put it out that the AACE and ACE did have a nice treatment algorithm back in 2020 for postmenopausal osteoporosis, which you could check out. So just as a review of what we went over today, you would consider osteoporosis treatment for those with a lumbar, spine, or femoral neck, or total hip T-score of less than or equal to -2.5, or if there's a history of fragility fracture or a high fracture probability. When you see that, you want to consider secondary causes for osteoporosis. You want to check their calcium and vitamin D levels and check out for deficiency and address causes for secondary osteoporosis. And then at that point, with osteoporosis, also recommend pharmacologic therapy and educate on lifestyle measures such as exercise, fall prevention, and also discuss benefits and risks of medication. And then they have a nice little algorithm for those who are at high risk. They had no prior fractures, or very high risk or with prior fractures. So if you search for the AACE postmenopausal osteoporosis treatment algorithm, that should pop up. But I do highly recommend this resource. And they also did have a nice document on their clinical practice guidelines on osteoporosis management. But that was my presentation on osteoporosis, and I'm very appreciative of you guys having me today, and I'm happy to answer any questions you guys may have.
Angela, thank you for a very comprehensive and thorough presentation. Very interesting. Our audience, if you have any questions, could you please unmute yourself? We're a small enough group that you could just unmute yourself and ask the question. Any questions for Angela?
So this is Elaine Bello. Do you have any pearls about management or diagnostic and treatment approach in males?
Yes. So there are medications that are approved for males. That includes the PTH analogs as well as, I believe, one of the bisphosphonates. I can bring that up again. Sorry, let me share my screen, looking for the option.
So what about actually getting their bone densities paid for?
That's a good question. So right now with USPSTF, there is no current recommendations on it, but per the National Osteoporosis Foundation, they do recommend 70 and older. It's insurance dependent. So if you are concerned for risk for osteoporosis or osteoporosis, one thing you could do is have the patient contact their insurance company to see if they cover it. Or also, if there are significant risk factors for it, such as hypogonadism, or if they've been on treatment for prostate cancer, they probably would meet criteria to suffice for osteoporosis screening. And at that point, hopefully that insurance should cover it as well. At the VA, though, it's different. There hasn't been problems with getting patients to get osteoporosis screening if they're 70 and older.
Any other questions for Angela?
Angela, thanks so much for great lecture, great slides. I just had a quick question about life expectancy. I saw one slide said something about not really consider if less than 1 year, another one saying less than 2 years. And
yeah, there's not much evidence out there. It's really more from expert opinion. But right, there's a recommendation to not consider starting osteoporosis treatment if there is a less than 1 year life expectancy. And then the 2-year segment was more on if a patient has been on osteoporosis treatments. If there's concern for less than 2-year life expectancy, then you can consider stopping it, or if they become bedbound. But that's a good question.
I guess
Angela,
if they-
there's a, oh,
yeah.
sorry, go ahead.
then it would increase. I mean, even if they have a 1-year life expectancy, if they had a fracture, it would improve their quality of life. I imagine that's why.
Yeah, and at that point, it would be like a risks and benefits discussion, just because those medications too. So with the bisphosphonates, you know, they would have to be sitting up after taking those medications, or they risk esophagitis or esophageal rupture. And then for something like Prolia, a Q6 monthly injection, even though you'd only worry about, you know, the injection every 6 months, but there's also risk with that medication, and you'd need to make sure that they're having adequate levels of calcium and vitamin D. So if they're at that point where we're concerned about, you know, appetite and ingestion of additional supplements, it could, yeah, the risk might outweigh the benefits.
Angela, there's a question in the chat. Could you elaborate on calcitonin and cancer risk?
That is a good question. I can't elaborate at this point, but I can get back to you and look a little bit more into it and email you about that.
Tiana, can you unmute yourself and ask?
Hi, sorry, lost my voice a little. I was just wondering for the I think there was a slide on after a fracture, you wait like around 15 days was the consensus. Do you know where that number came from? Because I think you said there wasn't really a like defined time period.
No, there's no defined time period. It was just from an expert consensus. There's no significant evidence out there, unfortunately.
Okay, thank you. I know we see that a lot, you know, in the nursing homes, but yeah, hopefully
Yeah.
more studies to show what, yeah, time frame.
Thanks, Angela. Any other questions from the audience? I see one on any recommendations on supplements to improve bone density, such as Algical.
When I went through the practice guidelines, I didn't see any mention about other supplementation besides just ensuring adequate calcium and vitamin D intake. But that's a good question. But yeah, I haven't heard about Algical.
Kiana's asking about, can we get the slides? Yes, we certainly can. And actually the video recording will be put onto our website. So if you want to watch it again, or if you know anybody who didn't make this one, then please go ahead and watch it. Oh, I have one more question that came in. Could you comment on the risk of stopping treatment with Prolia?
Oh, that's a good question. So unlike bisphosphonates, Prolia does not continue to work after discontinuation. So patients should be on Q6 monthly Prolia injections, but if they were to discontinue, they should be started on a different therapy starting 6 months after that last dose. Unfortunately, it's similar to calcitonin in that matter.
Okay. Michaela just put the link to the website where the recordings can be found. Michaela, could you also put the evaluation link in the website, please? Oh, there we go. Thank you, Michaela. So don't forget, everyone, if you want to get CME credits, then you do need to complete the evaluation form. And Michaela has just put the link into the chat. So you can follow that link to do your evaluation. Do we have any last minute questions for Angela? And I noticed that Tim is there too. Tim, it's lovely to see you too. Show us your face so we can see you. Hi, Tim.
Hi. Hi, everybody. I'm
Take
still
care.
at the office right now.
We miss you guys.
Yeah, we miss you so much.
I'm sure you're doing wonderful work in New York. So congratulations on everything. Angela, thank you for a wonderful presentation.
Thank
Come
you.
back and visit us, both of you. Come back to Hawaii to work if you can someday.
Sounds good. Maybe at some point.
Okay. All
Thank
right.
you,
Well,
guys.
thanks, Angela. Thank you so much.